Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about the fetal genetic mutations. Right. So let us first understand how does the fetus, my fetus, gets the mutations. Right. So meaning thereby that every single individual, right, all the human beings, male, female, whosoever it is, has got something around 22,000 clinical genes, and those clinical genes are in pairs, right? उनके दो दो pairs होती हैं या दो allele होती है, right? So out of these 22,000 clinical genes which are there in pairs, 7 to 8 genes are defective, meaning thereby that every single individual could be a carrier for that 7 to 8 genes which are defective. And but since I am a carrier for those particular genes, I don't manifest because मेरा जो second copy है वो normal है, and that takes care for the normal functioning of my body, right? But once I reproduce, जब मैं ये कोशिश करता हूँ कि मैं अपना बेबी करूँ, तो ऐसे possibility हो सकती है that I transfer that defective gene to the fetus. So that is one part. Second part is this, that we believe that all the human beings, they do have a DNA which is homologous to the extent of something around 97%. So meaning thereby when the male and the female or the egg and the sperm, they come together and then they fuse and the zygote is being formed. तो वो जो डीएनए है between the egg and the sperm is almost 97% homologous, right? And only the 2% and 3% of the DNA is different. Now, when that homologous chromosomes mixes together, meaning thereby that you are mixing the cow's milk and a buffalo's milk or a goat milk, and then when you want to separate it out, तो वो ठीक से separate नहीं हो पाता. So meaning thereby that during that sort of an division, the fusion of the egg and the sperm forms a zygote. That is a one single cell, right? From that one single cell, now we have to undergo a multiplication and division, multiplication and division, multiplication and division. उस एक सेल से हमको millions and millions of cells हमको बनाने हैं, तो वो multiply करके फिर reduce होता है. So meaning thereby that this unequal sort of an uh, uh, unequal sort of a division that would happen, and this can happen at any time, right? So this can lead to some sort of an unequal transfer of the DNA material or genetic material, that can lead to some deletions कि वो ठीक से separate out नहीं हो पाया, or could be duplications, could be sort of copy number variations, right? So this is what is happening. So now we do have two varieties of the genetic mutations that can happen to the fetus. One is an inherited, meaning thereby that comes from the basically into the DNA. Basically, it was there in the DNA of the egg and it was there in the DNA of the sperm. Secondly, once those egg and the sperm, they fuse together, and then the process of that division and multiplication division starts, and therefore we can have an unbalanced chromosomal translocation or DNA material translocation can lead to aneuploidy, which is called as a called as a Down syndrome, or chromosomal abnormalities. We can have a 13, 18, 21 X and Y. We can have an one nucleotide change which we call as an autosomal dominant, and therefore this could be manifesting, or on autosomal dominant conditions we can have a mitochondrial mutation that passes on from the egg to the fetus, and we can have a translocation. So translocation can also be de novo or inherited, right? So that is how. So this is the basic premise, that how does the baby gets the mutations. So I'll explain all these things via successive slides, and then probably we'll talk about it more later on. So look closely, right? So diseases can be classified in autosomal recessive, dominant, X-linked, and mitochondrial. So autosomal recessive, both the parents, they need to be carrier. Then de novo mutations. De novo meaning thereby that after the zygote is being formed, and therefore we can have these mutations which is not through the parents. Now this is 70 to 80% are usually autosomal dominant, right? Then we can have some structural deletions, duplications, inversions, right? So they can also be inherited and de novo. And then we can have a single nucleotide changes. We can have some deletions that happens with DMD. We can have copy number variations. Now, how do we optimize all these things? Is this that we optimize the health of the both mother as well as through the father, and then optimizing helps us in getting away with the epigenetic mutations, which is an environmental insults. And then we can, and so nut is this 70% it is inherited, and 20% could be the de novo mutations. This is case one. So you see to it that this father, that this one parent is a carrier for this six genes, and while on the other hand the second partner is not the carrier. This is the common scenario in which we identify that the proband is being affected. So he or she has got a homozygous mutations, and then we have done a prenatal identified as an heterozygous, right? So meaning thereby that we want to look around for beta thalassemia. Now this is the beta thalassemia carrier status, but out of this what we've identified is this, that a lot of permutation and combination happening, in which both the partners they can be carrier for a lot of genes. So this is a common scenario in which the parents they get, or the husband and wife and the partners they come together, they try to conceive, they do a baby, and then we identify that the baby is having some mutations. That mutation can be compound heterozygous, can be homozygous. Homozygous meaning thereby that if there is some sort of an element of an endogamy, they are getting married in a same sort of an area and all those stuff, which is called as an endogamy in the same ethnic area, or could be consanguinity, and therefore we can have an homozygous mutations, which I made you see in the first case. And then we identify that both the parents were carrier for the same genetic mutations, right? And then we offer a prenatal diagnosis in the second pregnancy, right? And then we identify that it is an heterozygous state. So this is a common scenario. This is a common scenario in which we identify that they were not knowing, or I was not knowing, that probably I was the carrier for some few genes that could be defective, and which I can pass on, because since I'm normal, since I'm a healthy normal carrier, so I'm clinically asymptomatic, I'm absolutely good, but I really don't know what is my genetic status. So once I plan for a baby, I conceive and deliver the baby, and then we identify that this baby has got some issues. Then we do the genetic mutation and identify that the baby is having an autosomal recessive condition. Now this autosomal recessive condition has to come either through the parents. So the father and mother, they need to be carriers. So they can be homozygous, meaning thereby we can have a same mutation, same thing deleted, like for an beta thalassemia. So the HBB is a gene in which both of them could be carrier, and we identify. So why I'm giving this example of beta thalassemia is this, that probably this is an indirect way of identifying somebody to be beta thalassemia carrier by doing an HPLC or by doing a CBC, राइट? सो हम ब्लड पिक्चर को देख के बता सकते हैं कि आप बीटा थैलेसीमिया कैरियर हो, आपकी जेनेटिक म्यूटेशन कराइए ताकि हम बेबी को थैलेसीमिया मेजर होने से बचा सकें। लेकिन ये कोई और जेनेटिक कंडीशंस के लिए ट्रू नहीं होता है, इन विच वी डोंट हैव एनी आइडिया दैट, और हमारे पास कोई ऐसा ब्लड टेस्ट नहीं है जो ये बता सके नॉन डायरेक्ट, अपार्ट फ्रॉम डूइंग द जेनेटिक टेस्ट, दैट प्रोबब्ली यू आर ए कैरियर फॉर दैट particular mutation, until unless you do have a baby which is affected with an autosomal recessive condition, right? So so what we can identify is that the fetus could be compound heterozygous or homozygous for a mutation, and then we identify retrospect बाद में जब मेरे पास बेबी एक हुआ affected, and then we identify कि भाई me and my wife both are carrier for that particular mutation, right? Second is the de novo. De novo is this, that probably we can have some de novo deletions in DMD. We can have a point mutation, we can have an X-linked condition, as well as a mitochondrial condition in which the my mitochondrial gene gets deleted, right? And gets transferred, because then it has to come through the egg and therefore gets transferred, and therefore we identify that my baby being uh, is being genetically affected. So inherited we can identify by doing a carrier screening. So it is a simple blood test by doing the carrier screening, both for the partners, both for the husband and wife, and then we can identify the carrier status. De novo germline mutations, it is very difficult to pick it up until unless you do have any suspicion, and then you do a testing to the fetus directly, and then identify the de novo mutations. So de novo mutations can be germline, can be in mitochondrial, and they can be de novo, right? So doing a carrier screening makes more sense, so as to identify the carrier status of anybody, so as to identify what is the genetic mutation that I'm carrying, and therefore we can prevent uh, these affected babies from getting birth, which anyways we would be doing. Anyways, we would be doing all this exercise of genetic mutations, carrier screening, both for the parents as well as a prenatal diagnosis, which anyways we would be doing in the second subsequent pregnancy. You getting my point? It is not something that probably we leave the patients to their own fate. All these things would be done after I have had a baby who is being affected. We identified that there is some genetic mutation, and therefore all this exercise would be done for the second pregnancy. So why not to do it pre-hand, meaning thereby that once I'm conceiving, once I'm planning, and whatever is the risk, it is always better to do a carrier screening instead of waiting for that one baby to be born in my family with a genetic mutations, right? Thank you very much for your patience.